I have the privilege of working with the palliative care service, and we do a lot of pain management. Obviously, it's one of our big functions on our service, and we meet a lot of interesting patients, very complicated patients throughout the year. And so I hope to present a patient case today surrounding the use of methadone. We have started using a lot more methadone over the last several years for a variety of reasons, and therefore I thought it was an interesting case that I would like to share with you. We'll talk about a lot of aspects of methadone use. So I'd like to open up by starting with a patient case. This is a 20-year-old woman who presented to the emergency room with severe right flank pain. We did not meet the patient until about day 8 of her hospitalization. At this point, the palliative care service was consulted. This patient had been seen through the pediatric services throughout many years prior to this admission. So she was in the pediatric unit for a variety of reasons there, even though she is technically an adult. And so palliative care, the pediatric services consulted palliative care primarily for pain management. When we met the patient, she complained that her pain was about a 20 out of 10 on a 0 to 10 pain scale. She described her pain as shooting, stabbing, and it was primarily in the abdominal region. Associated with this pain, she also had a lot of nausea, vomiting, and severe headaches at the time of this onset. She also kind of described this pain as an attack. So it didn't really come on with warning. It was just an all of a sudden type of pain. So it was very unpredictable. When we went through her medical history, she has quite a significant history. She was diagnosed as a very young child with a uterine sarcoma. She had undergone surgery, radiation therapy, extensive chemotherapy, and a bone marrow transplant. And she was currently in remission. And this was about probably 15, maybe a little bit more than that, years prior to this admission. She also had, as a result of some of the surgeries, she only had one kidney remaining. And what complicated this as well because of the surgery is that she had self-catheterization, so her bladder function was not working appropriately. Her renal function, her creatinine clearance, according to the one kidney and the data and the calculations, was estimated about 36 mils per minute. And she usually came in and out of the hospital quite frequently for pyelonephritis and urinary tract infections, although at the current time this was not a current problem. Some of her other medical history included cardiomyopathy, and this was due to some of the doxorubicin that she had received previously for part of her treatment for her cancer. In her medical records, it looked like her ejection fraction was fairly normal. It said low to normal. I don't have exact numbers of what her ejection fraction is or was at the time. She also has hypertension and fluid retention. This was, I think, bouts of being uncontrolled. However, at the time when we met the patient, was fairly stable. She also has a history of anxiety and depression, which is to be expected given her long medical history and complex problems. And then finally we come to the pain. And at the present time she was receiving pregabalin and also hydromorphone. And she had been admitted to our hospital directly from another hospital outside of the state where she had been having some procedures and things done there. And on her way back, I guess on discharge, the prescribing physician there only gave her 6 milligrams of hydromorphone, 2 doses, to get her back home, and then her primary care physician was to prescribe further opioids thereafter. And from my understanding, I don't believe she made it home. She actually came directly to our emergency room and in a significant amount of pain. There are some other significant medical history, which are some minor problems compared to these, which I won't cover at this time. Now, to complicate this a little bit further, we delved into her pain history. And she'd been on quite a few medications up to this point. And many of these she either didn't respond to or she had some side effects which limited her from wanting to retry some of these medications. She had previously been on a round of oxycodone. which she said was ineffective, and she suffered from severe constipation. Now, when we kind of talked to her more about this, it didn't sound like she was on a very good bowel regimen at the time or was non-compliant with the bowel regimen. So this is something that complicated that could have been potentially prevented in previous admissions. The fentanyl patch apparently didn't work very well. She experienced excess sedation from this. The pregabalin that she was on currently, when we delved into this a little bit more, it looked like she wasn't taking it. She was non-compliant. When asking more questions, she said she had a tremor from it, and she thinks it may have been titrated up too quickly. So at the present time, she wasn't taking the medication, although it was listed in her med history. She'd been on some trileptal and some lidocaine patches, which she claimed was ineffective at the time as well. NSAIDs were contraindicated because of her kidney disease, chronic renal failure, insufficiency. So we couldn't use an NSAID, unfortunately, in this patient. And then they had also indicated in her chart that she'd tried some, or been offered some non-pharmacological interventions, support groups and things like that, which she really wasn't willing to participate in at the present time. So when we met her, this was her pain regimen. She was on a PCA, hydromorphone. She was not given a continuous infusion or basal rate. It was just a demand dose, which was 0.6 milligrams every 30 minutes. And then she could be offered an additional 1 milligram bolus if needed for severe pain. And this regimen was not holding her appropriately. And when we had discussions with the physicians and the nurses, it was a little bit difficult because they really didn't want us committing her to a full drip, hydromorphone drip, because of thinking about discharge and wanting to get her back home in kind of the long-term goals there. We also recommended to put her on some hydromorphone IV push at the same time because we could use a little bit higher dose. We had some limitations because of the pumps that we were using. She was in a pediatric unit, and we were limited by the dose and the infusion rate that we could go up to. But needless to say, she really wasn't controlled on either one of these regimens. So at this point, we had some decisions to make. And going back to her original admission, thinking about what her admitting diagnosis was, they did a battery of tests and went through a lot of procedures with this patient. And the admitting diagnosis ended up being renal lithiasis or kidney stones. And it was a little bit of uncertain diagnosis as well because of all the scar tissue that she had in her kidney, the anatomical surgical problems that she had. It was a little bit difficult to tell on some of the CT scans whether this was truly the case or scar tissue or some other process going on. So at this point, we had a lot of meetings going on with our team, the palliative care service, pharmacy. We had a nephrologist, we had a lot of the pediatric physicians, we had the patient and the mother all meeting together to discuss the next steps for her treatment. And so what was proposed at this time was she had two options. Either one was to think about getting a surgical procedure done, having the kidney stone removed if in fact that was the case and that was the diagnosis, or trying to continue on with medication, with opioid management. So the patient and all of the team members kind of went back and forth and talked about the risks and benefits of each of these different therapies. And we also talked about the limitations that we have with the hydromorphone therapy, given the fact that we were using IV. At the time, we didn't have an extended release hydromorphone formulation to use. It was easy to discharge her on. She would have to continue to take the hydromorphone orally every 4 hours, but we could certainly do that if we needed to. Or we could think about some other options. As I mentioned earlier, there was a lot of limitations with the other medications, which she was unwilling to go back to try to use those again, especially the oxycodone, because that could have been an alternative with an extended release formulation that we could have used. So at this point, we thought about using methadone. Methadone has some advantages that we thought were good for this patient. And we had some extensive discussions with her. She was very hesitant to think about using methadone, the first thing that she thought about, of course, was the fact that methadone's used for some of the substance abuse and that. So that was one of the first hesitations that she expressed to us about using methadone. But we had some further discussions about its use in pain management and how effective that it can actually be. So methadone does have activity a little bit different than some of the other opioids. Although it does work at the mu receptor, it also works at the N-methyl D-aspartate receptor, the NMDA receptor, and this is where we think that some of the neuropathic pain can be treated. And this is why we thought this agent might be good for this patient, because some of the scar tissue and some of the surgical and chemo that she'd been through in the past probably left some neuropathic pain, which was a result from some of the tissue damage. So we thought that this would be a good agent for this patient to try at this point. Methadone is highly potent. It's probably one of the most potent opioids that we have. It's very effective for opioid rotation, so when you get patients who have tried everything and are on maximum doses, very high doses of other opioids, it's a very good drug to switch out to and give it a try and see if it works. It does have a fairly good pharmacokinetic profile. In your handout at the back, there's some tables. And in table 1 here, it talks about some of the pharmacokinetics. Now, some of these can actually be a little bit of a disadvantage for this agent, but there are some advantages as well. One of the disadvantages is that it does have a high volume of distribution, and this can potentially be a problem in patients who have a lot of fluid retention, have ascites, have pleural effusions, for example, because the drug can actually third space into that tissue, and you'll have problems with elimination and accumulation. Its half-life, if you notice there, is reported anywhere from 12 hours to 190 hours. Depends on what literature source that you look at. It's very variable and it depends on the patient. So unlike some of the other opioids or any other medications that we use, our half-life is usually a lot narrower than this. So this is fairly a limitation or something we have to keep in mind, again, because of the accumulation risk. It's metabolized through the liver to an N-methylated derivative, which is inactive, which is a positive thing because some of our other opioids that are metabolized actually have active metabolites that can accumulate in renal insufficiency and cause some more toxicities or enhance therapeutic benefit. With this agent, it is fairly safe to use in renal failure, which is an advantage, again, in this patient that we're talking about today. Its analgesic onset and peak analgesic effects are fairly similar to the other opioids, and also its analgesic duration. Even though it has a very long half-life, the analgesic duration is anywhere between 4 to 8 hours. So again, we don't really need an extended release formulation of methadone because of this. It does get a little bit tricky when trying to decide a dosage interval, so sometimes in the young patients we may dose methadone every 8 hours. In the elderly patients we may go a little bit more conservative and dose it every 12 hours and sometimes even further out to every 24 hours once they've been stabilized on an effective dose. One of the other big advantages of methadone is its low cost. It's about 10 cents a tablet. So this is one of the reasons that we've seen methadone being used a lot more in the last several years, especially in hospice, because hospice has a very limited budget of only about $10 a day for medication. So this is a great benefit here, and it works very effectively. Now, there are a couple disadvantages of methadone. I talked about its complex dosing a few minutes ago. You really have to know what you're doing when you are thinking about using methadone, because you can't just put somebody on it and titrate up. You really need to be careful because of the accumulation. You may have to adjust the dosing interval backwards a little bit. And again, there isn't really a well-established equalgesic dosage ratio when converting from one opioid to another, and we'll talk about that in a few minutes. I mentioned earlier the potential for accumulation because of its large volume of distribution, so again, something we have to look at and assess patients' medical conditions very closely. Also, over the recent last several years, there's been a lot of there's been a black box warning that's come out for methadone, and a lot of case reports with QT prolongation, which can lead to torsade de pointe, which is a fatal arrhythmia, and there have been some deaths reported with the use of methadone. So every time I talk about methadone, I always put this slide up as a kind of a warning and a caution, because, and especially when I talk with my students on clinicals, that we really have to make sure we're 5 steps ahead, thinking of where the patient's going to be upon discharge. If we're in the inpatient setting, or if we're in the outpatient setting, will the patient have good follow-up? So as a physician who's going to be managing the methadone, have they used methadone before? Do they know how to prescribe it? And do they know how to manage it? And if they don't, then I kind of step back a few steps and say, well, maybe methadone's not the right agent for this patient, because we really have to know how to manage it properly. Also, we have to look at patient factors. Is the patient willing to try it? Are they also capable of understanding the toxicities associated with methadone and taking it properly? So you can get into some problems here. There was a case report several years ago that was written up in USA Today about a fatal methadone error that was the prescription went out of the pharmacy as 40 milligrams every 3 hours as needed for pain, instead of every 8 hours around the clock. And the patient took it was like 16 doses within a 24-hour period and died. So you really have to be very careful, and you have to make sure that you counsel the patient appropriately on how to take methadone. So always be careful, ask those questions when you're thinking about using methadone for pain management. Some further dosing considerations here. We gradually and carefully titrate and initiate methadone. So again, knowing how to use it. There aren't some really good clear-cut guidelines. A lot of it is empiric, and the patient really kind of guides you through depending on how their pain is being controlled with the use of this agent. Cross-tolerance is incomplete, and what cross-tolerance is when you switch from one opioid to the other, you have different activity or effectiveness at the mu receptors. And so you may not have, because of metabolites of some of these agents, you may not have the same effect at the mu receptor, or the same number of receptors that are being bound to. And also remember that this agent works at the NMDA receptor, so you may get some additional activity here. And this is why we usually, when we titrate over, we start with a low dose and go up slowly instead of starting the patient at the full dose, and we'll talk about that in a minute. Again, there's a wide range in equianalgesic dosage ratios. You can get some severe toxicity if you're not careful. Conversion tables, we'll talk about those in a few minutes as well. So there's many different conversions out there. And one of the questions that we get quite frequently in the hospital setting is, okay, you've got somebody on methadone, and maybe they're having side effects, or maybe there's some other issues with it, and we want to put them back on morphine or another opioid. How do we backtrack and go from methadone to another opioid? There aren't any really good conversions for that. In your handout in the back, I think it's table 5 or table 6. Table 6 on the bottom of page 3, there is one reference to going backwards, and it's a 1-to-5 ratio. So that is something that we've used. I don't think it's been very well validated. It's based on a small number of patients, but it's really the only resource that I'm aware of at this point of going from methadone to morphine. But again, you have to be very careful. So coming back to our patient, what were we going to do at this point? At the present time, she was getting the dose listed on the bottom here of the slide, the 2 milligrams every 2 hours. She was using this around the clock and still claiming that her pain was more than 10 out of 10 on an hourly basis. So after discussing and having the many team meetings with the patient, her mother, and other pediatricians, we decided to start her on some methadone. And the first thing we had to do is back calculate to morphine, because all of the dosage ratios when we calculate to methadone are based on morphine equivalents. And her hydromorphone dose was about, 24 milligrams per day. So our first step was to calculate from hydromorphone IV to morphine IV, and then over to morphine oral. So this is the dosage conversions that are commonly used out in the literature. This is also in the back of your handout, which includes some other opioids in there. What's nice about these tables is that you can go from oral to IV or from one opioid to the other. So it kind of works horizontally and vertically. So our step one, as I mentioned, we need to convert to morphine IV, then to morphine oral, and then over to methadone. So if anyone has their phones out, I don't know if anyone's got their phone out or calculator and wants to check me and do the math. Given that she was on 24 milligrams of IV hydromorphone, if we look at the ratio of 10 milligrams of IV hydromorphone, which is equivalent to 1.5 milligrams of morphine IV, it's about a 1 to 6.7 milligram ratio. So you just set up the proportions, and this is equivalent to about 160 milligrams of IV morphine daily. And then that's in a 24-hour period. So we always make sure we calculate into a 24-hour equivalent. And then for morphine IV to morphine oral, it's a 1 milligram to 3 milligram ratio. So this comes out to be at 480 milligrams of oral morphine per day. So our next step then is thinking about what do we do with methadone. We have to get this patient started on somewhat of an equianalgesic methadone dose. If you look in your handout at the back again, there's a table, table 5, which goes through several different dosing methods for methadone. And if you notice up here on the slide, I've done all the math for everybody, so we didn't have to crunch numbers today. But if you notice, based on 480 milligrams of oral morphine per day, this comes out to be quite a wide range of methadone dose, depending on which formula that you use. Okay, so anywhere from 4 milligrams up to 60 milligrams a day, depending again on the different formulas. And that's our goal methadone dose. Okay, so we're not necessarily going to start the patient on that full dose that we've calculated here right away. We're probably going to start on a lower dose and maybe titrate up. Some patients may respond because of that incomplete cross tolerance. They may respond very well to a small dose of methadone. We don't really know, and therefore it's safer to start somebody at a low dose and titrate up to what we think is our potential goal for our methadone dose. What we actually use in our health system, our hospice physicians and our palliative care service, is we use the second method, which is the Mercadante method. So we're going to work on 40 milligrams of methadone for this patient. Now, I wouldn't say that one of these methods is better than another. It just depends on what your institution uses, what you're familiar with, what your practice is familiar with, and how comfortable they are with some of these formulas. There are some limitations to each one of these. So our goal, as I mentioned, was 40 milligrams a day. That's what we'd like to titrate up to. When we talked to this patient, she was, again, very hesitant to use methadone, again, because of the substance abuse stigma that's associated with methadone. And one of her stipulations that she mentioned to us, if I'm going to try this, I want to go really, really slow. I don't want to, overdose on the methadone or anything like that. So we started her out on 5 milligrams every 8 hours, which is a fairly low dose, especially given the fact that she was on a fairly large dose of hydromorphone. We did continue the IV hydromorphone, and over the first few days she was using about the same amount of breakthrough. It may have gone down by a couple doses per day, but in the grand scheme of things it hadn't really changed that much. Now at the same time, she did say that she didn't think it was working all that great. Now I don't know if she was telling us that because she still wanted the IV hydromorphone or not, but we could see a little bit by looking at her pain scores. They had gone down a little bit in the chart, and the utilization of the hydromorphone. On day 5, unfortunately, she did lose her IV access, so we had to kind of scramble and think about what we were going to do next, and we ended up putting her on some oral hydromorphone at 10 milligrams every 2 hours, and that seemed to hold her over until she got her IV access back. On day 6, we were going to titrate her up to 10 milligrams every 8 hours. At this point, and again, she was still on the hydromorphone for breakthrough. One of the other things I should mention quickly at this point is when you use methadone for maintenance therapy for chronic pain, do not use methadone for breakthrough because of the accumulation risk. So for breakthrough pain, always use another opioid. We often will use morphine, usually the concentrated solution, or oxycodone concentrated solution. In this case, we continued with the hydromorphone because we knew that she was responding fairly decently to it. Now, at this point, I have students on clerkship, and it was quite an exciting month this month because there was a lot of discussion with this agent. There was a lot of things to do and things to analyze with this patient's medication therapy. And one day they came into my office. It was, I think, late morning, and they said, you know, we were talking to this patient this morning, and she came in and complained that she was having some palpitations and her chest was fluttering. And so I freaked out, and I said, well, let's contact the palliative care service immediately, and we need to get a stat EKG, because I was thinking the worst about QT prolongation, torsade, and fatal arrhythmias that can occur with this. So at that point, we did order an EKG. We talked to the whole team, and everybody was on board with doing that. As you may recall, back in 2006 and 2007 was when the FDA reported some of the problems with methadone, that there had been some fatal deaths, life-changing arrhythmias that can occur, and as a result of this, a black box warning came out for methadone. A little bit about the history of some of the cardiac toxicity that can be associated with methadone. In 1973, there was a lot of use of methadone in substance abuse, and at this point, they started seeing some QT prolongation. However, the cardiac effects of methadone really weren't well published or known in the scientific literature. It wasn't until about 30 years later, in 2002, where there was a case series that was published in about 17 patients that noted that very high doses of methadone was associated with torsade and obviously fatal arrhythmias and potentially some deaths. In 2005, the MedWatch program reported 59 cases of QT prolongation and torsade in some of these patients. 8% of these were fatal. And again, this is what all led up to the FDA advisories and black box warnings for this agent. In 2008, there was another case series that was published. These patients that were in this case series had experienced near sudden death or fatal arrhythmias. They were put on an implantable defibrillator. Some of those patients, I believe it was 6 out of these 8 patients, continued on the methadone. 1 patient died, and 3 patients actually developed a fatal arrhythmia after that. So in this publication established the fact that if you've had a case of a fatal arrhythmia or torsade, that your risk is very high of developing this problem again. So it's not advisable if this event occurs to continue on methadone. You need to switch to another opioid. Throughout all of this time period, there were some medical examiner reports that have been published with methadone showing high incidence of deaths that have been noted on patients that have been receiving opioids. A lot of times these cases haven't been very well substantiated because they've been clouded by the fact that these patients are on multiple illicit drugs, maybe alcohol, so there are a lot of contributing factors. So it hasn't been very conclusive evidence that all of those deaths have been attributed singly to methadone. However, when you look at some of the data for like the Drug Abuse Awareness Program, and some of that literature does report that there's a disproportionate number of reported deaths with methadone compared to the number of prescriptions of methadone when you compare it to other opioids. Some of the clinical studies that have been published over the last several years, when they've been looking at the incidence of QT prolongation, have reported up to about 32% of the patients may develop QT prolongation here. So again, about 1/3 of the patients, which is quite significant. In all of these publications, what's been reported are some of the risk factors when they've gone back and looked at the patients. And most of the time, which kind of surprised me, is that These events have occurred in patients who receive a methadone dose of more than 100 milligrams per day, which is not very frequently what we see in the community. I've probably seen maybe 2 or 3 patients over the last 8 years who have been above this dose. And you may see this more in substance abuse than you do in pain management. Usually in pain management our doses are quite a little bit lower. However, you do have to assess risk factors in each individual patient. The IV route has been reported to be a higher risk than oral, although I've not seen doses associated with the IV. I've not used IV methadone yet. I've been asked 3 times to convert somebody over to IV methadone, and we've been able to avert it each time. IV methadone can be very caustic to the veins, so it's something that we try to avoid if we can, and it's suggested if you're going to use a methadone drip to use dexamethasone because of the irritation and problems that you can get with its administration. Some of the other medical disease conditions that can cause QT prolongation need to be assessed carefully. Hypokalemia, liver disease can also be a risk factor for developing arrhythmias, and then drug interactions. And in your handout as well, in the supplemental piece at the back, there's an extensive table of some of the drug interactions with methadone. So if you are using methadone, please rely on those drug interaction computer screen warnings that come up. Don't just keep hitting enter as we do sometimes. Stop and assess whether it's a high-risk medication for an interaction. In 2009, there was a publication in the Annals of Internal Medicine that there was a consensus panel that came together looking at all of the data of the deaths and all of the risks for fatal arrhythmias with the use of methadone, and they published some recommendations which are listed here. First one is to make sure we inform the patients of the arrhythmia risk. So again, this comes back to patient counseling, making sure they know that the risk is there and what to look out for. Also inquiring about the medical history, so get a good history on your patient. It's recommended that when we're starting anybody on methadone, we get an EKG prior to the start of methadone, at 30 days, and then annually thereafter. So this is very important in all of our patients here. Now notice on number 3 there's an asterisk there. And that asterisk means that if your patient has risk factors or they're on a high dose of methadone, you may need more frequent monitoring than what's suggested here. And then they also talk about if there is some borderline QT prolongation, to think about discussing the risks and benefits with the patient, whether they want to stay on methadone or convert to another opioid. Again, assessing the age of the patient, whether it's for palliative care, whether you're going after cure if it's a young patient, for example. And if the QT interval is more than 500 milliseconds, it's recommended to discontinue the agent. And finally, the last recommendation is looking at drug interactions. So this is very important as pharmacists to make sure we're assessing the medication profile for all of our patients. So when we come back to methadone here, what did we do for this patient? She hadn't quite received her 10 milligrams every 8 hours at this point. She had only, I think, received 2 doses at this time period. We had some lengthy discussions with the patient. We got together as a team, and because she had borderline QT prolongation, we contacted our hospice physician and said, what would you do, because this is the first time we've seen this in one of our patients, and she was young and she didn't have a lot of risk factors necessarily, at least her dose was very low at this point. And our hospice physician, who has a lot more extensive knowledge in methadone, recommended that we discontinue this. We talked to the patient at extensive lengths here. She was very upset about it, obviously, because her next step after this was to have a surgical procedure done on the kidney. So it's kind of, at least, you know, we told her that she gave it her best try, and we all did, and we hoped for the best. So we also, you know, talked to her about the risks of continuing the methadone and what might happen if she decided to stay on this medication. On day 10, we did a repeat EKG, which was within normal limits, so everything had gone back to normal, fortunately. And at that point, we discharged her, and she continued on her hydromorphone oral regimen, which was not ideal, but that was the only medication that she was willing to stay on at the present time. So just to kind of wrap up some key points here from the use of methadone, we are seeing methadone being used a lot more frequently than we have in the past. And just some stats that I've seen in the literature here, that we have about 250,000 patients who are using methadone for substance abuse, about 720,000 patients for chronic pain. I pulled out the MAPS data for the state of Michigan. The latest, unfortunately, that I have is 2009, but we have about 181,000 patients in the state of Michigan who have received methadone prescriptions. And that's been going up by about 5,000 to 10,000 every year, so I imagine we're probably close to 200,000 at this point in Michigan. Make sure that you do become familiar with the kinetics, know your drug interactions, make sure you check those, whether you're inpatient or outpatient, it's extremely important. And again, if you're recommending it or get asked questions about methadone, make sure you know where the patient's going to be. Ask those questions. Who's going to be the prescriber? Those are discussions that we have constantly on our team, because often we have patients who are not responding to morphine or hydromorphone or oxycodone, and they're in a lot of pain, and we automatically think about methadone, but at the same time we kind of look and say, well, is that patient going to be with our service or with oncology service, or are they going to go back to a primary care physician who doesn't have experience in methadone? So those are some things that we make sure we check out before we write that prescription, before we make recommendations for using methadone, and talk with the patient to know how compliant that they're going to be, and also extend it to the family, the caregiver, whoever will be taking care of that patient, to make sure that they're comfortable using this medication as well. One of the things we learned with this patient is make sure you check an EKG prior to starting methadone. We were fortunate that we had an EKG that was from a previous admission that we were able to compare, and that was normal. At this point it was borderline, and then it had returned back to normal. One of the things we would do differently next time is make sure we order that right before the methadone. Okay, so not relying on previous admissions for that, because we're not 100% sure could she have had QT prolongation for another reason. At this point we're attributing it to the methadone, but either way it was not safe to continue the medication. And make sure again that the EKGs are followed up at 30 days, and then annually, more frequently if there's problems or complaints or symptoms in between that.